the second would be Dr. Ajay Arora. So, Ajay, you will need to present again, but please make sure that there are no audio-visual glitches, please, because we couldn't take the timing into consideration.
And so first, Dr. Rajesh will present his paper on DME resistant to standard treatment.
Good afternoon, respected judges and my dear colleagues. So this is a practical problem which we face in our day-to-day OPD. So this patient has received 3 anti-VEGF injection, 2 DEX implants and 4 sittings of lasers, and still the patient has central involving diabetic macular edema. So what would we go ahead to do to treat it? So we came up with a novel solution for such patients where we designed a filter and asked the patient to look directly into the sun and see what happens to this. So this is 1 month, approximately about 30 to 40 microns of CMT has come down. At 3 months, approximately 50. 5 months, almost about 60 microns of thickness which has reduced. And about 7 months, there's a small recurrence of the edema at around 317 microns. So my study is basically the role of photobiomodulation in diabetic macular edema, which has been resistant to standard treatment, which is available today. Purpose of the study to evaluate the effect of photobiomodulation on eyes resistant or recalcitrant diabetic macular edema. So why did we look into recalcitrant? Because we included the worst eye. We didn't know whether this treatment will really work, and the need to be sure that we are not causing any further harm which is already present in these patients. So the concept was we took an yellow laser concept, which is the most macular friendly laser. So we took the yellow filter and tested it at Indian Institute of Science. And this is based on subthreshold laser photocoagulation of macular painting for these patients. So we wanted to involve this amount of energy for these patients with macular edema. So how did we do the study? Basically, we asked the patient to see the sun covering the other eye for 5 minutes per day at 9 to 10 a.m. in the morning, 5 days a week for 1 month. And only one eye was treated, the worst eye was treated, and the fellow eye was act as a control. The review was at 1, 3, and 6 months. How did we see for the adequate exposure of sunlight? We used the most sophisticated light meter and assessed the energy that was delivered. So this was a prospective study done at Shankaraya Hospital, Bangalore. Duration of study from January 2017 to May 2019. Sample size was 11 eyes of 11 patients. So the inclusion criteria were diabetic patients of more than 18 years who are willing to give consent, who had recalcitrant diabetic macular edema, which had adequate systemic control and willingness to follow up. Any systemic conditions which was abnormal, which could influence the outcome of the study, was withdrawn, like poor glycemic control, hypertension, nephropathy, and anemia. So what did we assess as far as the ocular status is concerned? We look into the CMT, which is a primary outcome, to see how the CMT responded to the treatment, and multifocal EIG and Humphrey visual fields to make sure that we are not doing any harm by doing this treatment to the patients. So did it really help? That's the golden question. So first patient I've already shown. This is the second patient in my series. 4 injections of anti-VEGFs in the pre-treatment. So pre-treatment it was 377, and within a matter of 2 months the patient reduced to 313 microns. More results is the third patient. The patient summary: 3 injections of anti-VEGF, 2 injections of DEX implant, and the patient had already undergone a PPV for thickened posterior hyaloid. See, the pre-treatment was 721 microns. A month later it was 569, and 3 months later it was 430 microns. The second question which comes into our mind naturally, did we do any harm while treating these patients? The scotoma which was seen in December 2018 in the same patient actually had reduced by March 2019, saying that the edematous area had decreased and the retinal function was much better. So further evidence, we looked into the multifocal EIG. The foveal peaking was still maintained, and there was not much of loss of amplitude or the latency. So did all respond? That's the next question. If you see, 70% of the patients responded very well to our treatment. When we said very well, anything in these patients, the reduction in the CMT should be considered, but we considered, let us say, more than 50 microns of reduction of CMT we considered. Less than that, we said that there minimal or no response. Even then, 70% of a patient responded very well. The range of response in the CMT was anywhere between 18 microns to 291 microns. So proof of concept. So once, whether the treatment is by chance or really did it help. So if you look into the treated eye, the CMT was coming down. When you look into the fellow eye, at the same duration in the first and third month, it was increasing and further increasing. And when we stopped the treatment, within the 3 months of stoppage of the treatment, the edema came back. So the recurrence was seen in 5 eyes by the end of 5 months, and persistent effect was seen in only 2 eyes by the end of 6 months. So the implication, it's a very simple but yet a very effective treatment in such patients where there is no hope. Functionals like subthreshold laser, it's not destroying any retinal tissue over there, it's actually rejuvenating the retina and the RPE pump, thereby decreasing the edema. When we look at the future perspective, added to this treatment, forget about the standalone, first let us add upon treatment to anti-VEGFs on steroids. It can prolong the effect of these, maybe prevent further injections altogether. And over a period of time, when we curtail tail and do much more better studies in it, maybe it becomes a primary modality of treatment in certain select patients. Limitations of study, we had a very small sample size because we got ethics clearance for only those patients who had worst edema, and we followed up only for 6 months. There was some variability of sunlight, somewhere it might be more, sometimes it might be less. We have light meters in our mobiles which can help to titrate these light sources and help us to get an adequate exposure for the patients. Questions to be answered, validation in a larger cohort, how long, duration of daily exposure, we should individualize. This was a cumulative energy that was given, but each patient, the edema might be different, CMT might be different. Can we curtail tail to individualize this better? When to stop? See, when we stop, there was a small recurrence of edema. So should we continue? How long should we continue? All these should be looked into. Long-term safety. To conclude, photobiomodulation can be used in treatment of diabetic macular edema, especially in such resistant and recalcitrant. Cost-effective, non-invasive, and self-administered, shows promise and alternative treatment to DME. Thank you.
Thank you, Rajesh. Very nice and interesting concept, considering that the cost is almost negligible.
Negligible.
I have 2 questions. One is, did it not just respond due to a better systemic control? What was the system?
As I told you, HbA1c was very strictly, and any of those parameters, we did an hemogram, complete hemogram profile, lipid profile, the glycemic control, and the RFT, all was looked upon and made sure they were very well in acceptable limits. Only then we included all those patients which had like systemic pioglitazone therapy or any other therapy which might influence the outcome was strictly neglected. That's why the cohort number was very, very small over a period of 2 years. We could include only 11 patients.
Okay, second question is, at the end of the day, we may be very happy with CMT improvement, but a patient would only want a visual acuity.
Exactly. I had written over there in a very small caps actually. We all agree that these people were treated, for years together, and the treatment itself, we could see 2 DEX implants, 4 lasers, and think it was almost of 1.5 years where the ECL is damaged, the photoreceptors are damaged, the heart plumps are coming over there. So obviously, even in several cohorts in which repeated anti-VEGFs were given, they didn't see any further improvement in the visual acuity because of the loss of photoreceptors. I think our cohort series of patients had severe damage. So
how was the visual outcome? Did the patients say at least subjective visually?
Majority of the patient, I would say about 80% of the patient, the vision maintained, it didn't deteriorate. And 1 or 2 patients had some amount of improvement. That was subjective. We couldn't really rationalize or did a p-value for it.
Okay, and one patient actually in which the subretinal fluid regressed, you could see the hard exudate clump forming.
Yes.
So aren't you worried about that?
Ma'am, these are like just desperate measures to decrease the edema. There's no other way we could treat these patients. So that's the only way that I could.
Sorry, you want?
No, sir, that's what
No, he had some question.
There were 2-3 things.
Yes, sir.
First one was a little more standardization was required about the conditions. See, when you have used that filter, for other purposes I've tried to get a filter, and the issue is about the exact spectral
Yes,
light which you would get. So maybe what you could do is put that yellow filter and get a spectral analysis to confirm.
We have done, sir.
Right. Second one was the presence of lens opacities, and third, lens opacities.
Yes, sir.
Third thing was about the natural light thing. Light meter you have taken, that's fair. So these 3 things which came to my mind, but excellent thing.
So one is that for the light meter we have validated at Indian Institute of Science. So the narrow band was between 570 to 580. So it had 99.8% of filtering only those wavelength of light. Second one, lens opacities, yes, it is not in a hand, but we tried to see all the photos which I had shown, they were relatively good. So the cataract was not that very significant in any of these 11 cohort of patients.
And one more thing which you could have done was to decide a point after which this is done in the, means if the patient has received an anti-VEGF, say, let us say in February, on February 15th, whether he will be included in the study
No, sir.
on
sir.
15th of March. That interval we had to, we had to fix to exclude the, whatever the residual effect of the pharmacotherapy.
So we included patients only after 6 months of any treatment, last treatment that
Last.
was given, whether it's laser, anti-VEGF, Osidex or whatever. 6 months was elapsed without any treatment because of frustration or inadequacy of funds or whatever it is. Only after 6 months was elapsed, we included these patients. These patients were never included immediately after any treatment status.
Rajesh, just come again about the cost of the device.
So the cost of device is negligible. Actually, the filter only, we took this filter because the larger the filter, the cost was high. But these filters, which are approximately 5 millimeters in diameter, costed us around 3,200 rupees. Each filter. Sir.
And it came fitted in that?
No, sir. We did that small because they had to have holding and they have to cover the entire eye, so only the fovea is exposed.
Right.
So we devised that.
Just one comment about what your thing about the cataract opacity and all those things. You could standardize it using the
Lock system.
no. On the OCT, you have that transmission amount,
Transmission,
so 5 on 10 or 6 on 10 or whatever. So that could help to standardize. Okay, the device used to test the wavelengths, etc. So that you purchased that device?
No, sir.
Or
It was done at Indian Institute of Science.
there
Sir.
itself,
We
and
didn't
you
have
just
it.
showed a picture of
Yeah.
it. Okay.
We just took the picture of whatever they provided,
Okay.
that this filter was pure enough to transmit only this transmission wavelength. So that's why we didn't.
I'm sure. Did you do any FAF or fundus pictures,
So
etc.?
we have done, but we didn't include any of these because it was beyond the scope and the.
So
the extent of it.
did the FAF pictures show any increase in hypo FAF spots or
So
something?
very
in
few
some of
because we didn't have in the first initial, but nowadays we are doing it. But I'm.
But that would
Quote
help
is, yes,
to
sir.
document. And I believe the treatment was done under supervision, the amount of
So the first initial
exposure.
teaching for the patient how to expose and the time duration, and we are one step ahead now. Even the light meters which are available in our phone are almost comparable to the Sikonic light meter that we procured. So comparable. So we said that whenever the light shows this much meter, you have to go and expose yourself continuously for 5 minutes. That's how we did it. So initially there was a teaching, and then they did it individually at home. They need not come to the hospital. They came at regular intervals to make sure that things are working out in the better manner.
And you fix the time of the day when they have to-
Exactly 9 to 10 a.m. So in the morning.
Okay.
Thank you, sir.
Very nice concept. Very good.
Now for the last paper, apologies to the next session. We are also conducting the semi-final simultaneously, hence we are taking another 5 minutes.
Good afternoon, Honorable Judges, Defense. I'll be presenting on suprachoroidal injection of triamcinolone with 30 gauge needle using a novel injection device. It's known that suprachoroidal triamcinolone reduces macular edema as shown by Deborah Goldstein in cases of uveitis. We also know that a single injection could spread to involve more than 50% of the posterior segment. And the catch is to use a micro needle, but a hypodermic needle which has a bevel of 1200 microns cannot be normally used to inject because it will become intravitreal because of the length of the bevel. Hence, we have two methods available by the Clearside group who had a microneedle with a bevel of 300 microns, or a microcatheterization, which means we have to incise the sclera, or a combination of 30 gauge needle through a 23 gauge needle, which has to be specially made. So I decided to construct a device so that we can use a commercial 30 gauge needle to inject suprachoroidal space injections, test the triamcinolone available in the Indian market, with scanning electron microscopy, and to test the ease of injection in goat size, and did a pilot study of triamcinolone in the human eyes. So the working concept of my device is that if you consider this particular rectangle, you have to travel from B to A. The distance traveled is less as compared to when you travel obliquely. So if you can change the angle and compare this to sclera, you can actually travel to a longer distance, and hence a hypodermic needle can be used. If you inject vertically with the same needle, it will become intravitreal, versus if you inject obliquely, it will become suprachoroidal. If you can define this path, one can have a nomogram, And we did this, we made this device, and this is what was zeroed upon. And this is a device which has got a base plate, it's got a window through which I can see the needle as it is traversing, so that I can have a bevel down, and the base plate has got a particular angle. So this is what is the angle alpha, and this is the triangle which is within the sclera, and this alpha angle corresponds to the external angle. So if we can have this angle changed, one can decide the length of the bevel, which will be intrascleral, and how much it will poke into the suprachoroidal space. We made this nomogram, and we decided that whenever we inject with whatever device, either 30, 35, 40 or 45 degrees, we will stick to the bevel travel distance of 1300 to 1400 microns. And with that, it was possible to go into the suprachoroidal space, and we also zeroed onto orocort, which was similar to Zuprata. We did this animal experiment, which clearly shows that once you inject into the suprachoroidal space, we dissected out the sclera, and we were able to demonstrate the presence of triamcinolone in the suprachoroidal space. We did U-beam analysis, and also injected methylcellulose-on-helon, and with the same device one could inject methylcellulose-on-helon, which may be useful for suprachoroidal injection and for buckling. We did this study in 44 eyes of 40 patients with a 30-gauge bevel down needle 4 millimeters from the limbus, and measured the central subfield thickness on day 7, day 30 and day 90, measured the intraocular pressure and best corrected visual acuity, and all cases of more than 270 microns of diverse pathology and macular edema were taken. The age range was 14 to 85, with the males 26 and female 14. There was no difficulty injecting triamcinolone in the suprachoroidal space using the device. There was no adverse events related to the drug or to the injection procedure, except in 2 patients where it became partly intravitreal, and patient had pain if injected in the horizontal meridian. So this is the distribution of cases. We had 28 eyes with DME, 1 eye with CRV with macular edema, 4 eyes with BRV with macular edema, 2 patients with vasculitis with macular edema, and we had 4 patients with choroiditis or uveitis with macular edema. So this is just to show how this device is being used in human eyes. And you can see here that it's very easy to give, and you are left with reasonably pristine conjunctiva. So here are some examples. This is a patient with a persistent diabetic macular edema who had received 8 injections of anti-VEGF, 4 injections of Ozurdex, and Ozurdex was not available. So we took a consent from the patient for a suprachoroidal injection, and you can see here pre-injection on the 10th day, 34th day, and 70th day. So patient responded dramatically well, and this effect was there till about 88 days in this patient. Another patient with a persistent diabetic macular edema, where again patient had received anti-VEGF and Ozurdex, and we injected Skita, and were able to demonstrate a response on the 2nd day itself, and there was a progressively reduction of the macular thickness. A patient of vasculitis who was one-eyed patient, underwent cataract surgery, developed cystoid macular edema, where anti-VEGF was given, did not respond. We gave Skita to this patient, and there was a dramatic response in 3 days' time, with the visual acuity improving from 636 to 639. So when I compared on the economic front, and if the entire country was using Ozurdex versus the entire country using Skita, we'll end up saving about 62.4 crore of rupees. Also, the amount of plastic that is wasted in Ozurdex would be minimized, and hence it will be useful not only economically but also from the environmental point of view. So in conclusion, a suprachoroidal injection space with a 30-gauge needle can be injected with triamcinolone or any other drug. The effect of Skita in a pilot study has lasted for about 60 to 90 days and is comparable to Ozurdex. The recurring cost of suprachoroidal injection once you bought the device is only about 150 odd rupees. This device will allow injecting any other drug which can be used in the suprachoroidal space injections. It has other advantages. It is autoclavable, can inject to varying depths, therefore even in a myopic patient it can be done, and maybe it will be possible to use it for suprachoroidal buckling, because we have tried injecting helon in these cases. Thank you for your attention.
No, since everything, yeah, just oven fresh it is.
Sorry?
Oven fresh it is, I said. Your presentation was there, so.
Thank you, sir.
Excuse me, can I ask?
Yes, sir.
So Clearset Pharmaceuticals have stopped the suprachoroidal injections of steroids, like stating that they do not have additional benefit compared.
So the reason is not that that's the additional benefit they've stated, but what I learned from Dr. Phil Rosenfeld, who had come from VSI, is that Clearset Group was asked by the FDA to give some animal data on certain things, and they were not able to provide the animal data, and FDA has prevented them from going further. Clearset company, the whole company is made on the concept of a microneedle. So if the microneedle itself, animal data is not there, the company flops. So that is the biggest problem. So they cannot come out open in market and say that it's not working. It's because they were not able to provide animal data to the FDA. That is where these things have been stopped.